All right. Want to welcome everybody and apologize for getting on a little late. We were just sort of hashing out some of the topics that Dr. Addrizzo-Harris is going to be covering here. So let me share my screen quickly, or maybe not as quickly as I think I am.
Mary, do you want me to get started?
Is my screen up?
Yeah, your screen it just came up.
Okay.
Yeah, we're seeing the slide deck, and not in viewing yet, but
Yeah, it's like,
It's thinking.
yeah.
I'm blaming Mercury in retrograde. That's always my story, and I stick to
There
it.
you
All right, let's see. Feel like my system's not cooperating. All right, well, it skipped the first screen, and yeah, it seems like it is sort of thinking. So, welcome everybody. My name is Mary Kitlowski, and I'm with the nonprofit Running on Air. And our mission is to help others breathe more easily through access to oxygen appropriate to their needs. But one of the things we also do is offer webinars like this. There's a lot of wonderful conferences happening throughout the year on bronchiectasis. We just had one in New York that was very informative. And so we're partnering with NTMIR to be able to bring this to you, a summary, because we know people can't, throughout the country can't attend in person. And a lot of you want to know what's up and coming and, what things are affecting your disease, our disease. So these are our social media if you want to follow us online, social media. And we are going to be having a bunch of webinars next year, 7 highlighting highlights from the various conferences. So we have a list here. The only one that it's not a highlight webinar, but on portable oxygen concentrators, and that's January 22nd. The rest of them we're reaching out to doctors like Dr. Addrizzo-Harris to do those for us. So those will be on our website once they're ready, and we'll share that link to our website so you can check if any of these conferences look interesting and you want to attend those webinars. All right. I apologize because, yeah, my screen is not showing any of the images. So should be a picture of Amy. There should be a picture of me. We will be your moderators today. And I am going to turn this over to Amy, who may or may not have images on the next slide. And she
And
does
we do
not.
not. Hello, everyone. My name is Amy Liebman. I'm president of NTM Info and Research. We are a patient advocacy and support organization for patients dealing with non-tuberculous mycobacterial infections and other related comorbidities, including bronchiectasis. We have patient education materials. We offer webinars, and we also have a pamphlet called Insight, A Patient's Perspective, which you can order for free. We have an extensive support group network. So if you're looking to join a patient support group, you can visit our website at ntminfo.org. And our latest offering, which I wanted to let everybody know about, if you are coughing and you go out in public and you find that people look at you funny, you can order buttons that say, "My cough is not contagious." They are free, and you can go onto ntminfo.org and order your buttons and let your buttons do the talking for you. I'm going to turn it back over to Mary now.
And Amy, I'm making my own button. I was saying this somewhat during the conference. Coughing is my superpower.
I like it.
Okay, I think this was another NTMIR slide.
I've said everything I need to say. We're good to go.
All right. I apologize for not having the image here, but thank you to Insumed for supporting this event today. Without the support of companies like Insumed, we would not be able to bring you these programs or the other work that we do. All right, so a couple of housekeeping issues. This webinar is being recorded. The recording will be emailed once it is online. And I just wanted to let everybody know we're a little behind on getting our webinars up. I hope this will be up by the end of December. We will not be taking questions during the webinar, but you can put your questions in the Q&A and we will get to as many as we can. Dr. Addrizzo-Harris cannot give personal medical advice. You will receive a post-webinar email from us in the next 48 hours. And since we had a glitch with some of our graphics, we will include the links for NTMIR and some of the other info, just so you have that. But you will receive that in the next 48 hours, so you can look at anything additionally that we talk that is discussed in the webinar. And Amy, I don't know if you can see this, but it decided to skip. So if you can go from there.
Sure. So I'm going to introduce today's featured speaker, whom many of you already know, Dr. Doreen Addrizzo-Harris. Dr. Addrizzo-Harris is the Fiona and Stanley Druckenmiller Professor of Pulmonary, Critical Care, and Sleep Medicine in the Department of Medicine at the NYU Grossman School of Medicine. She has an extensive background in bronchiectasis and non-tuberculous mycobacterial infection and medical education. She serves as the Associate Director for Clinical and Academic Affairs and is the Director of the Bronchiectasis and NTM Clinical and Translational Program at NYU. She is now serving her 24th year as the Program Director of NYU Langone Health's Pulmonary and Critical Care Medicine Fellowship. She is currently the chair of the Clinical Care Network Steering Committee of the Bronchiectasis and NTM Association. She is also the chair of the annual North American Bronchiectasis and NTM Symposium at NYU each December. She has served as the chair of the 6th World Bronchiectasis and NTM Conference in 2023 and is the past president of the American College of Chest Physicians and the Association of Pulmonary and Critical Care Medicine Program Directors. She is a passionate educator on the topic of bronchiectasis and NTM and is focused on bringing high-quality care to patients living with these diseases. She has lectured extensively on bronchiectasis and NTM lung disease and is a primary investigator, a principal investigator of many clinical trials in bronchiectasis and NTM lung disease. We're going to hand it over to Dr. Addrizzo-Harris now to give us some highlights.
Dr.
Great.
Addrizzo-Harris, based on our timing, let's go to about 45 and check in.
Okay, thank you so much, Mary, and thank you, Amy, for inviting me to give this update on the North American Bronchiectasis and NTM Symposium that we held at NYU on Tuesday and Wednesday of this week. Thank you, all of you, for joining. I know some of you may have joined our patient symposium on December 1st, and I did want to tell you we were having some glitches there as well. So our full recording of that 3.5-hour session will, by the end of December, be posted on our NYU website, and we will send a link out to everyone who had registered for the patient symposium, both in person and online, so that you have that full link. We are sorry about that. But today I wanted to go through the topics that were covered at the bronchiectasis and NTM symposium on Tuesday and Wednesday, and it was quite an array of topics. In addition to having the CME portion of the program, there were 9 workshops, and there was also a full abstract reception. So I will hit on some of the abstracts that were also submitted. So there was a lot of discussion at this meeting on how one should work up a patient that presents with bronchiectasis. And we know, based on some of the new guidelines that came out, there was a session on the new recent European Respiratory Society bronchiectasis guidelines, and also on the chest American guidelines that will be coming out hopefully in early 2026, that working up patients for the cause of their bronchiectasis is extremely important. Right now, based on the clinical workups that are occurring, we still don't have the answer for about 2/3 or a little more of the patients that present to us in knowing what the etiology is. And so there was a lot of recommendation at when a patient presents to a provider, for that provider to not only make the diagnosis of bronchiectasis, but think about the type of bronchiectasis that's being presented. Where is it on the chest x-ray and on the chest CT scan? Is it upper lobe disease? Is it middle lobe disease? Is it lower lobe disease? What other comorbidities is it presenting with? Is it presenting with sinus disease in a younger person? Is it presenting with just middle lobe disease and NTM lung disease in a middle-aged or older female? In order to be able to think about what the possibilities of diagnosis of etiologies or of causes are. And some of the areas that are missed quite frequently, particularly in the United States, are some of the genetic abnormalities. So there was a recommendation to think about working up patients for possible genetic causes of their bronchiectasis, not only for cystic fibrosis, which we know occurs in children and young adults, but cystic fibrosis can occur even in middle and older age patients. So if the disease is particularly upper lobe, if the patient has other organ system problems with sinuses, perhaps with their GI tract, sometimes you can have pancreas abnormalities, etc., to think about cystic fibrosis, to think about primary ciliary dyskinesia, another diagnosis that is often hard to make, but is often missed and can present in adulthood. And now even there was a section on talking about screening patients for what we call cystic fibrosis membrane mutation abnormalities, CFTR mutations. And those genetic mutations are many. There are several thousand that can be measured. And sometimes patients with non-cystic fibrosis bronchiectasis have some of these mutations. They don't qualify for having cystic fibrosis, but sometimes by having one of these mutations, and if you also have what we call a sweat chloride level that is not normal in the intermediate group, you may benefit from one of the genetic therapies, the modulator therapies that we give patients with cystic fibrosis. And sometimes being on modulator therapies can actually cure the co-infections that you may be living with. So that's something to ask your physicians about, if you should be tested for CFTR mutations, if they've thought about genetic disorders in you. Another area that was talked about significantly was there were several sessions on immunodeficiencies and how that is extremely important as some of the basic blood work that should be done when a patient presents with bronchiectasis. Much of the time, patients have their immunoglobulin levels measured, IgM, IgG are some of the names you may have heard, IgA, and that is definitely important to measure those, but that is not where it should stop, particularly in patients who are having recurrent infections. You should also be getting your what we call your pneumococcal antibody levels drawn, and if those are not sufficiently elevated in the normal range, then you should be boosted. Your doctor can tell you how that is done, and then those titers should be remeasured to make sure that you have what we call an appropriate antibody response. So this is one step further than what was recommended in the prior guidelines. Now, a bit more of an immunologic workup should be done, and if you do not have adequate immunoglobulin levels, or you do not have an adequate booster response, then you should have further studies done and be referred to an immunologist. Sometimes repleting patients with intravenous gamma globulin can be the first step to preventing further exacerbations and many of the infections that our patients get. So very important to have that looked into. There was a lot discussed in another area that is more commonly than we probably diagnose, cause of bronchiectasis, and that is very bad reflux disease. We had some of our GI colleagues and one of our GI surgeons speak about the workup for a recurrent aspiration, and particularly in patients who have lower lobe disease. Gravity brings these secretions that affect the lung and destroy the airways to the lowest portion of the lung, the lower lobes. Patients in those cases should have a full GI workup, often with an endoscopy and what we call a manometry study, to look and see if they are aspirating, and many of the patients are asymptomatic. They don't know that this is happening. Along with, in some patients, depending on if they have swallowing disorders or are coughing when they're eating, a swallow assessment to make sure that when they're swallowing, they're also not aspirating. Because some of these aspiration events can be modified, as many of you know, by lifestyle changes, the most important ones being elevation of your bed at night to 30 degrees with a wedge, and not eating close to going to bed, usually a 3-hour window before going to lie down after you've had dinner. Two very, very important pieces. Many patients are given antacids in forms of what we call proton pump inhibitors or H2 blockers for their acid reflux, but that does not stop the mechanical issue of the secretions coming up. They may now be neutralized, but they often still persist and can still cause aspiration that you don't know. So having that kind of workup is quite important. And then I think the third thing, which is extremely important to remember, is to make sure that your physicians are sending cultures on you, not only for bacteria, but also for mycobacteria, the NTM that we're looking for, and also for fungal organisms. Often patients who have what we call allergic bronchopulmonary aspergillosis, which is a common cause of bronchiectasis, certainly in certain countries like India, and even in certain parts of Europe, is a small part of what we diagnose here in the United States, and may be overlooked because it's not being diagnosed adequately. So having titers done for aspergillus, looking at an IgE level, looking at the amount of eosinophils you have in your blood, and checking sputum for fungus such as aspergillus is quite important when you're thinking about the possible causes of a patient's bronchiectasis. So that's a lot of what we heard on causes and workup and etiology. There was, and I won't spend a lot of time on it because you've had other webinars, but there was a lot from Dr. James Chalmers on inflammation as the cause of bronchiectasis, talking about a lot of the new DPP1 inhibitors that are out there. The one that you know of, which is FDA approved, brensocatib, was discussed. There were several panel discussions talking about who should get treated with brensocatib, and there are a lot of questions on what are the best groups. We know certainly patients who are having frequent exacerbations, and those who are also very symptomatic, even if they're not having an exacerbation, are patients that we're actively treating. There were questions on, should patients who are being treated for NTM lung disease be treated with brensocatib? And the consensus was that if they're still exacerbating and still have significant symptoms while being treated for NTM lung disease, that most of the providers would agree to start brensocatib. What about patients who have immunodeficiencies? That group was excluded from the ASPEN trial, but most of us are feeling if a patient is on IVIG and being replaced, but still having some exacerbations, we would feel comfortable watching them on brensocatib, and even patients on low doses of prednisone may be candidates for brensocatib. So there are many other categories outside of those that were studied in the ASPEN trial that we would feel comfortable using brensocatib in. And most of us are feeling that since there were some improvement in pulmonary function studies, particularly the rate of decline was reduced on the higher dose of 25 milligrams, and the quality of life measures were better in those on 25 milligrams, we would start patients on 25 milligrams and watch these patients closely. There was a discussion on, let me move on, I'm in my little book here. There was a lot of discussion on what to do with patients who are exacerbating, who have Pseudomonas. We know patients with Pseudomonas are those who are at highest risk for progression. And so those are the patients that really need to have a treatment started early on, especially when they are first diagnosed. The ERS guidelines actually recommends eradication of Pseudomonas. So if you are a patient who has had many sputums done and Pseudomonas had not been diagnosed before, and then all of a sudden you have a specimen that is showing Pseudomonas, that would be a question for your provider to think about the risks and benefits of trying Pseudomonas eradication. The ERS guidelines, which were discussed, recommend Pseudomonas eradication. What is that? Well, that's a prolonged course of antibiotics, often started with oral antibiotics or IV antibiotics against Pseudomonas, several weeks of that, followed by inhaled antibiotic regimen for at least 3 months to try and eradicate the Pseudomonas. So that's one thing that definitely should be considered. But in those patients who either eradication is tried and it's not successful, eradication is probably about 40% of the time successful. So if you're a patient where it is attempted and your Pseudomonas doesn't go away, or if you're a patient who is having chronic Pseudomonas and you have been getting treated every time you get sick from a Pseudomonas exacerbation, you should talk to your provider about going on long-term therapies to try and reduce your exacerbation rate. And some of the options are chronic macrolide therapy, which is recommended in both of the guidelines, which is 3 times a week, usually azithromycin, or going on an inhaled antibiotic. Usually the choices out there in the US that we have are tobramycin, inhaled colistin, or inhaled caistin, and those are usually done 2 weeks on, 2 weeks off, or 1 month on, 1 month off, going on those to help not only keep the Pseudomonas at a reduced level, but also to prevent exacerbations. And again, now that we have a DPP-1 inhibitor, the question may be, well, should we try the DPP-1 inhibitor first? Again, it's looking at risk and benefit to the patient. We know the safety profile for brensocatib is very good. Your doctor may decide in you the first thing they want to try is a DPP-1 inhibitor. And if that reduces you somewhat, but not fully, then add a macrolide after that. Right now, we don't know the best way to start therapies. We know we've got options, and in each patient, it will be individualized. We also heard a little bit about the care center networks that was described in the patient session. And again, they are being rolled out. As you know, I chair them. We have now 58 centers. Dr. Patrick Flume has submitted, and it has been accepted, a publication talking about the care centers and what they stand for and what type of staffing each center should plan to rise up to, meaning that the care of patients with bronchiectasis and NTM disease takes a lot more than just me or just a provider. There are lots of healthcare individuals that need to be part of the team, and those include respiratory therapists, dietitian, social workers, pharmacists, as well as a lot of the other subspecialties who work together with us, ENT, GI, pulmonary rehab, thoracic surgery, and you name it. So getting each of the centers to have a core of these patients and make a core of these healthcare providers and making these providers more available to our patients is what we're looking at. How can we make them available virtually? How can we share them across centers? So there was a lot of discussion on that, and hopefully the publication will be out in early 2026 for all of you to read. There was a bunch of discussion on Mycobacterium disease, both refractory MAC. So refractory MAC is usually defined as patients who are on therapy for MAC and at 6 months still have not converted their sputums. There was a lot of discussion on what therapies are coming out for MAC. What should we do in that refractory MAC group? Right now, the only FDA-approved drug for refractory MAC is adding on Arikayce or inhaled liposomal amikacin. Some of the other options of what to do if a patient is refractory, particularly if they cannot tolerate MAC or they have a reason that they can't go on MAC in the Arikayce in the first place, would be to change your therapy from 3 times a week to daily. Another option is to add or substitute clofazimine into the regimen. So there are some other options. The hope, though, is, and there was a lot of discussion on this by Dr. David Griffith and Dr. Kevin Winthrop. They did a debate on what are the best 3 drugs. We know that azithromycin and ethambutol are key in therapy. And why is that? Well, azithromycin, we know, is the mainstay drug that kills the MAC organism. And ethambutol is extremely important to be paired with azithromycin because it prevents the organism from becoming resistant to azithromycin. So you need that combination. Most of you know that azithromycin or clarithromycin monotherapy alone with no other paired antibiotics is something we do not do in patients with MAC because you can become resistant. But what would be that next 3rd best drug? And most of us feel like it would be inhaled liposomal amikacin, but started up front with the azithromycin. So there are several studies that Dr. Chuck Daly talked about, and we will soon have the results of the ENCORE trial that looked at using Arikayce together with amikacin. It's better together with azithromycin and ethambutol up front, compared to just using azithromycin and ethambutol alone. The preliminary results look good, and we're hoping to have an answer on that trial by the time ATS rolls around in May. And then we're very, very hopeful that we'll be able to start using that drug up front in patients with MAC lung disease. There was a lot of discussion as well on, an omadacycline trial that was used for M. abscessus patients, and omadacycline it is an oral form of what we call tigacycline, which is an intravenous drug some of you have heard about that treats M. abscessus. It is a much easier to tolerate, causes a lot less nausea. It is currently FDA approved for community-acquired pneumonia and seems to be extremely effective for mycobacterial disease. So there are hopes that that drug will be able to be used potentially in patients both with MAC, and many of us are already using it for M. abscessus. There was a lot of discussion about the management of patients with M. abscessus lung disease. Some of the important points that came out from Dr. Shannon Kasperbauer's lecture were that it's very, very important to know if you are converting once you are on therapy for your M. abscessus. So that means you really have to have your sputums followed. There were several studies that were discussed where, physicians were not getting adequate follow-up in sputum samples. So it's really, really important to make sure you're dropping off those sputum samples so we can tell when and if you convert. And in patients with M. abscessus who did not convert, there was unfortunately, a significant increase in mortality. So we really need to focus on those patients who are not converting early on. And some of the recommendations are to be much more aggressive in that patient group, going to IV therapies earlier on. I know everybody really, really would like to avoid being on IV therapy, but we know that some of the oral and combined nebulized antibiotics are not as potent as our IV companions. So starting with an intensive therapy regimen for M. abscessus patients is extremely, extremely important. And there was a long session on when to think about surgery. We had 3 phenomenal thoracic surgeons there, cases presented by Dr. Flowers and Dr. Shannon Kasperbauer about when should you consider surgery. And so really, surgery should be considered in the list of choices for any patient right up front. And usually when I see a CAT scan, I say, is this patient at any point in their treatment a possible candidate for surgery? And that will make you think about it, or have your provider think about it early. Because if you do have localized disease, or maybe you don't have localized disease, but you have 90% of your most severe disease in one place, surgery should be considered for you, particularly if you have cavitary disease or if you have a lung that is very much destroyed. And it should be considered early on, particularly for patients with M. abscessus, but even in patients who have macrolide sensitive MAC disease, because we know converting sputums is sometimes impossible in patients with cavitary disease, particularly if you have a large thick-walled cavity. So we like to think of early, because if you don't think about it early, then it gives the disease a chance to spread to other parts of the lung, and then you may ultimately not be a surgical candidate. There was a review of the other reasons why patients should consider surgery. The other big area is certainly patients who are having hemoptysis or coughing up blood. That's a time when you're going to want to think about removing the area where the bleeding is coming from. But often, and almost always, when you do surgery, you must have adequate drug therapy on board, hopefully for at least several weeks before you go on to surgery, so that the healing can be complete. That's extremely important. What other therapies were discussed for patients who are refractory to antibiotics? Well, we had Dr. Jerry Nick, who is from Denver, talk to us about phage therapy. These are viruses that love to infect bacteria and mycobacteria. And there are several labs in the country that are collecting and housing phages that are particularly useful for patients who have mycobacterial disease. So far, the banking is better for those patients with M. abscessus compared to Mycobacterium avium, but there is banking being done for all types of Mycobacterium currently. And phage therapy looks to be hopeful in patients who are at a stage where they're not getting better from the pharmacologic therapy that they may be on for M. abscessus or for MAC and are continuing to progress. National Jewish is doing a study particularly for cystic fibrosis patients, and they have two arms. Patients that are being matched with phages are going into one arm. They are administering the phages intravenously. Phages can be given very easily twice a day, and those patients are getting at least a year of intravenous phage therapy along with their antibiotics to see if they can convert the sputums and improve the symptoms and improve the CAT scan. I'll let you know that we have a phage trial ongoing here at NYU as well. We have enrolled at this point 4 patients in our trial. We are doing non-cystic fibrosis patients who have either failed or who are progressing on therapy for Mycobacterium abscessus or persistent MAC. And right now we are also doing intravenous therapy with the hopes that we will be able to do a combination therapy of intravenous and nebulized in the near future. So more to come on phage and how that can be useful for patients who have a very severe disease. There's also several discussions on how to detect mycobacterial disease early on. There was a discussion by Dr. Tony Yu, who was at Tulane University, has a whole team, a whole lab there, looking at what we call biomarker detection in the blood in patients with NTM lung disease, looking at a way to detect DNA in the blood of MAC patients very early on, and being able to use that not only for diagnosis, but also for monitoring treatment response. And how wonderful would that be if I can tell you tomorrow if you've got MAC, and not having to wait 6 or 7 weeks for your sputum to grow. And also the hope would be to use it as a marker of response to treatment. So there's going to be a lot more coming on that. We call it, actually, CRISPR is the name that's being used to describe this therapy. And there is a multi-center trial going on, which many of the big centers in the country are part of: NYU, Oregon Health University, the National Jewish, et cetera, and many more are taking part, so that we may have an answer in patients being treated with MAC lung disease. There was a really innovative talk by Dr. Patrick Flume on AI assisted diagnosis for patients with bronchiectasis. And so now with a company called Therona, Dr. Flume and others are working on being able to diagnose the amount of bronchiectasis and amount of mucus plugging that is seen on CT and being able to quantify it so that we know exactly how much mucus is in the airways of patients with bronchiectasis and be able to say, after airway clearance, did we improve that? And on a follow-up CT, being able to measure that again. It was also used as part of as a sub-study for the Aspen trial. Dr. Chalmers presented some of that data at CHEST, looking at AI-generated assessments of CAT scans showing potential slight improvement in bronchiectasis in patients treated with anti-inflammatory drugs. So is there, particularly in this case, brensocatib, so is there a possibility that they not only stop inflammation, but potentially do they reverse some of the bronchiectasis that has formed? So that is a very, very exciting area that we will be hearing a lot more about. There were several talks on the microbiome, one by a phenomenal researcher at NYU, one of our prior fellows and now faculty, Shivani Singh, looking at lower airway dysbiosis and which phenotype it predicts in patients with NTM lung disease. We'll talk a little bit about that in a second. And then Dr. Leo Segal gave a wonderful talk on a more general topic on microbiome in bronchiectasis. And Dr. Chotramal from Singapore gave a talk on the gut-lung axis and the microbiome there in bronchiectasis. So we know that the microbiome, the bugs that are at microscopic levels in our lungs and in our guts, play a very, very important role in predicting who will get NTM, who may get what types of NTM, how those patients will respond to therapy potentially, what will happen to those patients once you eradicate Pseudomonas, how the microbiome changes, and then can show what organisms take the place of that Pseudomonas that was there prior. A lot of this work is being done at the translational level, and the hope will be that there may be a point we'll be able to analyze someone's microbiome and be able to say what they are at risk for or what type of treatments would be best based on the microbiome that we get from a patient, because we know what we're seeing in the culture dish from sputum that patients send us is quite minimal, does not represent 90% of what's in the microbiome. So a lot more to come on the microbiome in both bronchiectasis and NTM. We also had a very nice panel discussion on what are some of the challenges in the community, particularly with community physicians. A lot was centered around the inability for physicians to have time to be able to educate their patients on airway clearance, having patients to have to come back for several visits, not having access to respiratory therapy at the level that was needed, not being able to get sputum analysis to the degree that they wanted. So again, all of these challenges in the community are one of the reasons why there's a delay in diagnosis and often a misdiagnosis, and people not understanding what they're dealing with, thinking it's asthma, thinking it's recurrent bronchitis, when really it's bronchiectasis. There was a lot of discussion on the use of inhaled corticosteroids in patients with bronchiectasis. There was a consensus that there's too much use of inhaled corticosteroids in bronchiectasis. And I think in that area, any of you that are on inhaled corticosteroids should be sure to ask your providers, do you need the inhaled corticosteroids? If you're an asthmatic who's bronchospastic, that may be very well indicated for your treatment plan, but there are a lot of patients who are on inhaled corticosteroids, and no one has questioned whether or not they're being, if they're being useful in the care or the treatment. And they can, as we know, not only increase NTM infections, but certainly can increase other co-infections, such as bacterial infections and fungal infections. So if you're using one, make sure that it's absolutely necessary. So at this point, I think I will stop and I'll turn it back over to Mary and Amy, and I'm happy to answer questions for anyone who has one.
Yeah, we do have a few questions in the chat or the Q&A. Thank you very much, Dr. Addrizzo-Harris. That was a great summary of everything. So you touched on AI, but this is a slightly different question on AI. Is AI research being considered for potential drug therapies for NTM, Pseudomonas, or fungal?
I'm not aware of that, so that I would not know. I don't know the answer to that one.
Actually, I can chime in on that. I do know of one company that is using AI to increase the speed of screening phages through a phage library to try to speed up the rate at which you can screen phages for possible matches to a particular strain.
That's very interesting. There are a
Yeah.
number of companies now, Amy, getting into that area.
Yeah, everybody.
All right, Amy.
I see some of the questions. If you want me to go through them, Mary,
Sure.
We
Yeah.
can, we can read,
or you want to pick
them
them?
out.
Yeah.
Go
Yeah,
ahead.
no, we'll read them out too, so that
Okay,
we,
go
if
ahead.
somebody was asking about, there's a New England Journal of Medicine trial that was in September 25, it was published. Can nebulizing help different types of bronchiectasis, more severe or positioning amount of daily sputum production? Are more specific trials warranted?
Right. So that was the New England Journal of Medicine trial that came out of a group in the UK, and they looked at saline and I'm blanking on the other drug, carbocystine. And it was actually a negative trial, but the numbers were very small. There was an editorial that went along with it. The carbocystine, we all agree, is not useful as a nebulizing agent. However, hypertonic saline, there was a trend to improvement, even though it was not statistically significant. What I think we all learned from that trial, and what we're learning from the guidelines that are coming out, not everybody needs a mucolytic agent. Airway clearance is much more than that. So postural drainage may be the best thing in one patient, where exercise may be the best in another patient, whereas huff coughing just with an aerobica might be fine in someone else, vest therapy in another patient. So the best patients that benefit from a mucolytic such as hypertonic saline are those that have mucus that's often thick and copious. So we're starting to think about not using hypertonic salines as a standard in everyone, but modifying it across the patients depending on how they're presenting.
Thanks. I know there was a little discussion of this. So if one eradicates one gram-negative pathogen, do folks usually just get another different one?
So actually there was a case that was nicely shown at the seminar where when Pseudomonas was eradicated, then Mycobacterium came back and filled the space. And then when they got rid of the MAC, the Pseudomonas came back. So yes, and that's partially, part of the microbiome. I think when we see a bad pathogen, and the bad ones would be Pseudomonas, Denotrophomonas, Klebsiella, or a Chromobacter. Those are some of the names we don't like to see. We'll try and eradicate it, because I'd rather be dealing with a MAC or an H influenza instead of those other organisms, because those other bugs, sometimes you don't have to treat, and sometimes are easier to treat with an oral regimen. So that's one of the reasons really to target a select group of bad bugs. But you are right that it probably will be replaced by something else.
Okay. Okay. Yeah, so we were just looking at that question. We were just talking about that question. Somebody asking about authorization for the HIV vaccine.
The HIV vaccine. So you can get the H flu booster vaccine. So we don't do it in our practice, but we will send you to an immunologist. So if you're having recurrent H flu infection, or if you're somebody who's got a common variable immunodeficiency, you probably need to get other vaccines tested. And my recommendation would be to go see an immunologist.
Okay. The next question is, can you talk about bronchiectasis and COPD? Is there a connection? How is it diagnosed? What are the treatment options? And would bronchiectasis become COPD over time, or I guess vice versa?
That's a very good question and a very hard one to answer, but there's definitely an overlap syndrome. So there's a significant percentage of patients who have both diseases, bronchiectasis and COPD. Probably 20% have COPD. Bronchiectasis alone, when we're saying COPD now, I'm talking about chronic obstructive pulmonary disease caused by either smoking history or secondhand smoke history, or biomass inhalation. But let's think about, when we use the word obstruction, lots of things can cause obstruction on a breathing test. Asthma can cause obstruction, bronchiectasis can cause obstruction, and so can emphysema or chronic bronchitis. And they're not all COPD. So bronchiectasis can have progressive obstructive changes on a breathing test, but it doesn't turn into COPD. Often when you have COPD, it may be a prior smoker who's got COPD, but also has an overlap syndrome of bronchiectasis. And they both have to be treated somewhat individually. So a patient may be on separate meds for their COPD and then separate meds for their bronchiectasis.
All
All
right.
right.
So have there been reports of adverse effects with Brinsupri that are not in the list of side effects? And
No, not yet. No, I mean, the most common side effects, as most of you know, are the periodontal disease, which patients with periodontal disease were excluded from the trial. What we're just recommending is patients who go on Brinsupri to get good dental exams twice a year. And then skin disease with a thickening of the skin on the soles and the palms. And that was very minimal. But no, there hasn't been a report of any other significant side effects that have occurred. And those get reported to the company, et cetera. So I'm sure if there is something that should come about, we would hear about it from the company. But no, none that I know of. Well tolerated.
All right. Can nodular disease become cavitary?
Yes, actually it can, unfortunately. So nodules can themselves cavitate. So the same area that is infected can then go on to cavitate, or you can develop a cavity in another part of your lung if your disease is not controlled that wasn't infected at all in the first place. So that's one of the reasons that in patients who do have NTM lung disease, particularly if they're not being treated, it of course depends on the severity of your disease and how much MAC and whatever you have in your sputum, that you should have CAT scans done to monitor. So that's one way to pick up cavitary disease early on.
all right, we're down to just a few minutes left, so we might have time for one or two more questions. Was there any discussion on best labs for testing sputum?
So there wasn't, but I can tell you that there's a working group working with the Bronchiectasis and NTM Association led by Dr. Ann O'Donnell that is talking about that, going to be addressing that specifically, microbiology, what the basic lab should have, and she's going to be addressing some of the commercial labs as well.
All right, and there is a question on converting sputum, and that's something we can send out in our email.
Perfect.
Yeah. So can the DNA blood analysis be used instead of having to do a bronchoscopy to see if you are hiding MAC at the back of your lungs? Doc wants to prescribe azithromycin to treat frequent pneumonia.
So I don't know enough about, we don't know enough about the DNA analysis as of yet. Right now, it's being correlated to patients who are growing MAC in their sputum, people that you might think based on their CT scan have MAC, and but their sputums are negative. We don't have data on yet, but I expect we will. If you don't have any sputums, remember, if a doctor is going to put you on azithromycin 3 times a week for prophylaxis, You do want to make sure that you've had a number of sputums that do not show MAC. And if you have a CAT scan that looks like MAC, but you're not growing it on sputums, you could discuss having a bronchoscopy to make sure you're not positive before starting the azithromycin.
All right. Well, that's all the time we have. Sorry that we can't get to the other questions right now. We'll see if we can get those answered for you at some other time, though. I want to thank Dr. Addrizzo-Harris again for doing this webinar for us. It was very informative. It's always nice to hear what's up and coming, and that so many people are doing research on bronchiectasis and NTM. And I also want to thank Amy for her partnership with NTMIR and throughout the year in helping to bring these webinars.
Thanks, Mary. Looking forward to next year.
Yep.
Thank you for inviting me, guys. I'm always happy to help out anytime.
Thank you. Thank you
Thanks.
so much. Thanks everyone, and have safe and happy holidays.
Same to you. Happy holidays, everyone.